All right, good morning, everyone. Welcome to Pediatric Grand Rounds. Today our speaker is Dr. Amy Harper. She's a pediatric neurologist, associate professor of pediatrics at Children's Hospital of Richmond at VCU. She serves as the director of the Pediatric Neuromuscular Clinic. Dr. Harper trained at Brody School of Medicine and completed her fellowship training in neurodevelopmental disability with additional training in neuromuscular diseases at Oregon Health and Sciences University. Her areas of interest include muscular dystrophy, cerebral palsy, neuromuscular disability, and neuromuscular diseases. Please join me in welcoming Dr. Harper.
Good morning, everyone. Hopefully it is not quite as warm in Roanoke as it is here in Richmond. I think we've all, summer has definitely arrived. Thank you for having me today. I'm excited to share with you one of my new ventures, which is to help share information concerning early diagnosis of muscle disease. I wear a number of hats here at VCU, where I am the neuromuscular specialist and sit on a number of committees for recruitment. Additionally, I run our MDA, our Muscular Dystrophy Association clinic, and I also participate in a neonatal care clinic and provide perinatal consultations. Have a number of outside interests through the Muscular Dystrophy Association, as well as other parent organizations, including Parent Project Muscular Dystrophy and the Jet Foundation. And I also do mission work to Nicaragua, serving a group of Duchenne Muscular Dystrophy patients there. And that's done through the Richmond Global Health Alliance. As part of my position, I do a number of clinical research trials, both in cerebral palsy as well as muscular dystrophy, and do have some disclosures regarding different industry studies that I run with Sarepta and Avexis, as well as NIH trials with that include primarily cerebral palsy. A list is there on the slide as well. So I always like to start at the beginning and where the story starts. The young man all the way to the left is Dr. Barry Russman. He was my primary mentor in what I considered a motor disabilities pathway. I always joke to the residents and students that I was on an extended pathway, and I think when I was done, I was actually a PGY8. Dr. Russman introduced me to this young man with a beard who was Dr. Bob Leschner, and I thank him for creating the foundation for neuromuscular clinics here at VCU. Interestingly, Dr. Leschner was working with Dr. Susan Sparks, the young lady in red, at National Children's, and they were doing research together. My paths crossed with Dr. Sparks learning about with a combined research in congenital muscular dystrophy. And when she moved to Charlotte, North Carolina, she brought me with her, where I met Dr. Liu, who's the gentleman in the glasses, and we did translational muscular dystrophy research for limb-girdle muscular dystrophy. And then the lady on the far right is Dr. Teasley, and she held the director position here at VCU prior to me joining the group, and she was instrumental in recruiting me here to Richmond. Dr. Eric Hoffman, who's at the bottom, is another colleague for translational muscular dystrophy research. He has worked with a group that I'm involved with called the Collaborative International Neuromuscular Research Group, which is a network that runs a number of clinical trials for muscular dystrophy. And it was very instrumental because this was the largest natural history trials that we were able to run through this network. And they're now used as the controls for several studies, which have allowed us to decrease the time that a child may need to be on the placebo and still show an effect in the study. So today we're going to do a case presentation. We're going to talk about how to assess weakness at different ages. I'm going to do a review of the natural history of Duchenne's muscular dystrophy and how that has changed. Talk about the important components of a neuromuscular clinic, and then I'd like to discuss some new and upcoming therapeutics for the treatment, specifically for Duchenne's muscular dystrophy. So I hope that by the end of this talk, you'll be able to identify motor delay and weakness in children, or improve that ability, that you'll know when to get a blood test called a CPK, and that you'll have some general knowledge about the treatment, which includes standard of care for Duchenne's muscular dystrophy, as well as new therapeutics that are on their way. So I always start with a case presentation. I tell the medical students that each story is, or each clinical vignette is one that I personally provided, or a patient that I saw. Otherwise, there would be no value in giving more personalized lectures. So this young man was 5 years old, and he came to me as a toe walker. His birth history was fairly uncomplicated, full term. There were some cysts that were noted on an early ultrasound, but these resolved prior to delivery, and he went home within about 2 days. His developmental history was timely. There was no significant delays. He was walking by 13 months, and even by age 4, he was able to pedal a bike with training wheels. There were no language delays identified, no adaptive delays. He was in preschool, and no concerns about his learning had come up. He did have a history of some laryngotomy tubes, but otherwise a very benign birth and developmental history, and no medical complications. There's no family history of any children with weakness. He was an only child. This is his parents' first child. Interestingly, the parent, particularly the mother, went to the pediatrician and with the concern that he was not keeping up with his peers, particularly in running. And she'd also noted a recent onset of the toe walking. And at that point, she endorsed no difficulty going up and down stairs or getting off the floor, no tripping or falling, or no other signs of concern. I saw him at this point, or shortly after, and a couple of things that were notable for his exam is that he did have mildly enlarged calves, and his heel cords were a bit tight. I did have him stand from the seated position. He did not use his arms to do so, and he's 4, so I have to rely more on functional assessment for a lot of my strength evaluation, and at least initially he was not showing any significant difficulty. Then when I had him run, he began to propel his arms a little bit more and showed a little mild sway in his back, or some lordosis. I then repeated the what I call the Gowers maneuver, where the child sits on the floor and has to stand up, to make sure he tired first, and then repeated that part of the evaluation. And he did put one hand to his knee upon standing. I have some nice videos to demonstrate this a little bit later. His reflexes were intact. There was no sensory losses. The remainder of his neurological exam was reassuring. So just a couple of pearls and for some audience participation. At what age can you reliably perform manual muscle testing on a child? Any thoughts at all? And I think you can use the chat function to chime in. Hopefully I can see it pop up. About 4 comes from a Dr. Haynes. Yes. So reliably, it's a developmental age of at least 5. I certainly have had some 4-year-olds who have been able to participate with manual muscle testing. But before that, you really need to rely more on your history, particularly for your gross motor skills, and then rely on just observing the child in the room. and doing different functional assessments. So I always have the parent place the toddler on the floor, and I carry a ball in my bag, and for some reason they love to go out and play in the hall, and I will throw the ball, and then they'll stand up from the floor. I got to see if there was any Gower sign, and then they never walk after the ball. They always run after the ball. So then if there's any mild proximal muscle weakness, I can see if there's like a little waddle, and then they have to stoop and recover to pick the ball up. So you can learn a lot just from doing that one thing. I would warn you that sometimes the nurses, they don't always place the children in shorts, and it can be more difficult if they're wearing a lot of clothing to see some mild waddling with that. So I've talked a little bit about the ball and how I use the ball. I'll also hold it above my head, and I use it more of a squishy ball, so that they have to grab it and actually actively resist it to try to take it from me, and I never let them have it initially. And that's a really nice way to assess, because if you put your hand right behind the scapula, you can feel if there's any scapular winging at the same time that they're resisting the ball overhead. I do find there's value of keeping a book nearby, because a lot of times, particularly with toddlers or a child with a developmental disability, they might not be able to sit still or relax. So I often will have the child sit on the parent's lap with a book, reading the book, so that then I can kind of sneak under that book and check the reflexes with good reliability. So definitely remember your shorts and a couple of other tools, and this would make your exams a little easier. So beware of the toe walker. I see a lot of children with toe walking, and I know that a lot of times it's considered more idiopathic toe walking, but there's a couple of other things that can cause toe walking. One, if you do have proximal muscle weakness, like we expect in this child, it kind of shifts their gravity, center of gravity forward, and then they come up on the toes as a compensatory measure. So a proximal muscle weakness may be present with a toe walker. A lot of my patients who have hereditary neuropathy or CMT, they are also toe walkers because they have weakness with ankle dorsiflexion. And so then they get tight behind or at the heel cords and become toe walkers in that way. The children who have a club foot, they can also have more of a perineal neuropathy, and that nerve is real important for bringing the foot up and turning it out, so they can also develop more of a toe walking gait. I think the other group is if there's an underlying tether. So it just always take a second look at your toe walkers and make sure that you don't see weakness either proximally or distally. So this is a video that will show some toe walking and how we will, how just changing the function, you can demonstrate subtleties in your exam. So this boy here, you can see that he's running. There's increased use of the arms. He's a little bit up on his toes, and then when we get a side view, you can see that there's a little bit of increased lordosis or sway in the back. And what I find really interesting in this video is if you look from the back, you might not necessarily pick up on subtle differences with him. So if we had just walked him in the clinic, we may not see that increased lordosis or that mild waddling in his gait or his propensity to go up on his toes. What about the infant, and how can we assess for weakness in an infant? Well, a lot of this depends on your tone examination. Remember with the tone examination that we typically will look at the resting posture of the baby. Always remind medical students to make sure that when you're examining the infant that the head is in the midline, so you're not activating the AT&R and get a difference in tone from side to side. So the other piece is that there is a progression in tone naturally that allows the child to then go on and develop other skills such as rolling and sitting and with that progression of tone is the disappearance of primitive reflexes, so that you can achieve that next milestone. Always a couple of maneuvers that I particularly like. If you look at the bottom, this child is being pulled to sit. So I would suspect weakness in the child at the bottom because the arms are fully extended. There's a decrease in the traction response. And then there's this prominent head lag that's present. Interestingly, even in infants and toddlers with Duchenne muscular dystrophy, this head lag can be prominent if you look at it very closely. And I have had some therapists actually refer patients who they've noted had some weakness with neck flexion, and then later was found to have a muscular dystrophy. The next picture here is doing horizontal positioning. So you're looking for active kicking of the legs and active flexion of the arms and the legs, and is, of course, the head coming up to the midline and turning laterally. Above it towards the top is a nice picture that demonstrates vertical suspension, looking for slip through. And again, this is a nice position to look for active kicking. So in our neonatal follow-up clinic, we actually do a Hammersmith or Hind, which is a neurological evaluation focused on the motor examination that has several features of the Ballard in it, and then we score it looking for babies that are at increased risk. The same standardized test is used for monitoring progress and treatment in spinal muscular atrophy. The other pieces that you can look for is your reflexes, and of course your primitive reflex, and your both the stretch reflexes and the primitive reflexes. I think the primitive reflexes in any infant are very important. I particularly like the gallants because when I have them here in horizontal position, I can then look to see if they can activate their muscles in their trunk. And I think that that's just a good guide to tell me if that child is weak or not. I did want to point out that if you have the baby who slips through, who has this kind of ragdoll appearance, whose posture is that such that the arms are extended and the legs are kind of in that frog leg position, and you find no reflexes, that this is potentially a medical emergency, that child needs to be referred to a pediatric neurologist quickly. And I would encourage you to just call the pediatric neurologist and have them seen in 1 to 2 days, because if you call me, then I can actually send SMA gene testing or spinal muscular atrophy gene testing that same day. And we do have gene therapies that if I can get in place very early, we can certainly change the outcome for babies who traditionally would pass within the first 1 to 2 years of respiratory failure. So if you see a floppy baby that you think has weakness and don't find reflexes, that is a medical emergency. So here are some of the things that we've talked about in looking for weakness. This is the looking at the posture of the baby to see and seeing that the arms are extended and that there's a frog leg position. The middle picture at the top, it shows the picture of more of a facial weakness with that open mouth posture, and you really don't see a lot of facial expression. This child probably, this is the face where I typically see more with like a myotonic dystrophy. And I promised, that I would show you another video. Please chat in if you can't see those. But this is the Gower sign, and it does not always have to look like both arms are being used to climb up the legs. Like this young man, he just has a widened stance when he pops up. So back to the localization, I wouldn't be a neurologist if I didn't talk about that. But we're always trying to figure out what's in the brain, what's in the spinal cord, what is in the peripheral nerve, the neuromuscular junction, or maybe in the spinal cord at the anterior horn cell. And I like this table because it reminds us of where to localize that lesion if we're not seeing reflexes, or if we are seeing muscle atrophy. Is it more likely to be distal or proximal? and what distribution to expect. So our child falls more in the myopathy category. He has intact reflexes. He doesn't have any sensory losses. So if we follow this table, we might expect him to have an elevated CPK and possible muscle disease. There are some pediatric resources for approach to motor delay. These can be found through the American Academy of Pediatrics. There's also a very nice website called childweakness.org. And if you're not aware of this website, this is what it looks like. And it has a number of different videos at different ages to help to identify weakness. It leads you through algorithms of when to test a CPK, or when to refer to a specialist. But I think it's a very underutilized website because not everyone is aware that it exists. So hopefully you'll have a chance to take a look at this and pass it on to others as well. So here's the algorithm for motor delay, which is picked up on a well child check. And it talks about doing a number of developmental screenings. I think probably by the time that you've gotten through several of these visits at 9 months or 18 months, and then did some additional screening tools and took some additional history, you may have lost a little bit of time here. What I would suggest is, or what I see most often, is that once it's identified, there's this referral directly to early intervention and or to a physical therapist. But I would say that we may need to change this algorithm just a little bit and add in parent concern, because here I would probably go with the parent concern that the child was not keeping up with the peers, or maybe starting to have toe walking associated, or maybe also had some language delays, and go straight to getting the CPK and the TSH, particularly in a boy in that scenario. And we may even want to move our larger arrow up to this same box that indicates to check the CPK. So just a few of the red flags that would prompt more urgent evaluation. We've talked about having absent reflexes. If you ever see tongue fasciculations, that would be another more urgent referral. If you see abdominal breathing in a hypotonic infant, this is also a medical emergency. So my SMA1 babies who have abdominal breathing early don't do quite as well. And I like these clinical pearls because it does include the parent concerns, and it turns out that about 80% of the parent concerns are accurate, that there is going to be some kind of underlying reason for that motor delay. So I take those very seriously, and I, again, would just go ahead and get the CPK. Particularly, as I said, in boys who have both motor and language delays. And I get a lot of referrals for elevations in CPK. These are not small elevations. These are elevations that are 10 times normal, where they're in a more dystrophic range. So if the number is like 200 or 300, there's probably a different reason for that, but it does have to be taken in context of exam, because if you don't have a lot of muscle mass, you might not be able to generate a high CPK. I would say about 2 to 3 times a year, I do get a referral from a gastroenterologist where the AST and ALT were elevated. Some of the kids may have already had an ultrasound of the liver, and they're young, they look relatively normal, and they have forgotten that that the AST and ALT are non-specific, and it's actually the CPK that has resulted in those elevations, and the CPK was 10,000. I think one of the boys I diagnosed once, he was less than 6 months of age at the time of diagnosis. He was undergoing a failure to thrive evaluation. Liver functions were noted to be elevated, Then the gastroenterologist actually checked the CPK because he couldn't find a liver etiology. And that boy ended up having Duchenne. So it's one of the youngest patients that I had diagnosed. We talked a little bit about toe walking, and I guess the other main clinical pearl is to make sure that you always do testing early. So if you haven't heard me say this already, with motor delay, go ahead and get the CPK. And about this time is when I have all my residents and students and pediatricians chime in that if I say motor delay, you say CPK, and we all do it together. So what happened with the case that I presented earlier? So the mother actually Googled toe walking and slow running, I guess the Google MD. She did call her pediatrician and she says, I'm concerned that my son has Duchenne muscular dystrophy based on this Google search. The pediatrician did not see the patient. It was the same pediatrician that he had followed since birth. But it says, there's nothing I can do. I will refer you to a pediatric neurologist. The boy then saw a community neurologist. He says there's no signs or exam findings to support Duchenne's muscular dystrophy, but based on the parent concern, he did check a CPK. So this was 2 days before I saw the patient. The CPK was 16,000. And I did see him the next day, and we were able to get the test, the gene test in the clinic and get a very early confirmation for him. Matter of fact, I think he's now in clinical trials and is doing quite well. But this was a lot of undoing. So definitely a case that I always like to share because it's an emotional diagnosis already for me to tell you that your child does have muscular dystrophy, but to be told repeatedly or given the impression repeatedly that your child didn't have it, it was a lot of undoing for this family. The average age of walking for muscular dystrophy is at 18 months. Does anyone have some idea of what the average age of diagnosis might be? No one's chatting in. So it's actually 4 years and 10 months, and the range is between 3 to 5. I want to bring this to your attention because this is normally the cycle where the family is beginning to have a second child. MD StarNet is a demographic study that where we find new cases of Duchenne's, and we can then look to see when did they maybe show the first motor delay to the time of testing. And they actually collected data on 156 boys who didn't have any family history, and were able to find that the boys had onset of symptoms beginning at 2.5 years. They got their first evaluation by the primary care doctor around 3.5, and then the first CPK was done closer to 4 to 5 years of age, with a diagnosis at 4 years and 9 months on average. And the typical time frame from the time of the identification of the delays to the diagnosis was 2.5 years. They are looking at newborn screening for Duchenne's muscular dystrophy. There were some initial pilots that looked at CPKs in the newborn period. And there's a lot of things that elevate CPK. So if you do have a family history, it may be worthwhile to get a CPK on an infant, particularly if there's a sibling or a cousin who has Duchenne's muscular dystrophy. If it's done within the first couple of days of life, though, I would encourage you to repeat it because there's a lot of other things that can increase that number, and you want to know if it's trending down or not. More recently, I had probably in the last 3 years, I've had one pediatrician who checked a CPK at the 2-month well child check. So that child was diagnosed by 3 months of age. And then I had recently a sibling of a patient who, again, got tested at birth. And we actually made that diagnosis at 6 weeks of age. So always check your family history, look for motor delays. Another tests I like to perform in the clinic is just with jumping in addition to running. And a lot of the boys, because of their proximal muscle weakness, are unable to jump. Or they have kind of this jump where they're able to jump off of one leg, but then kind of teeter, and it's not really a true bunny hop or jump. The child who's not keeping up with their peers with running or jumping on the playground, toe walking, and I think we've touched on all of these. Difficulty with stairs is another one. You'll see them kind of pull themselves up the stairs with the use of their arms. This just shows some features with the calf hypertrophy, the lordosis. Here you can see some scapular winging, and this boy is going to show you the traditional Gower's maneuver. How do we get to an early diagnosis? For me, I give a monthly lecture to the medical students, a yearly lecture to both pediatric and neurology residents, trying to increase everyone's knowledge for early detection, and hopefully they'll tell 10 of their friends, just like you might today, and then we can all work together for early diagnosis. And I think just knowing about that child weakness website also helps to educate others. Next year, I'm doing a talk with early intervention for early detection, and my PTs, who are also clinical evaluators for Duchene's muscular dystrophy and are certified Duchene's PTs, they do a lot of education within our system for other PTs. So we have a number of outreach programs that are pretty active. Can't remind you enough, motor delay is CPK, but also parents' concern. So what is Duchene's muscular dystrophy? So this is the most common muscular dystrophy. It occurs in 1 in 3,500 boys, and there's about 2,000 diagnoses per year. It is X-linked, and 60% are deletion, 5% are duplication, and the remainder is point mutations. But I want to bring to your attention that not all of them have X-linked inheritance. There's about 30% that are spontaneous gene changes where the mother is not going to be a carrier. Once the boy is diagnosed and it's been genetically confirmed, then we always have a genetic counselor in our clinic to meet with the families, who will then do carrier testing for the mother to determine if this is truly X-linked. Interestingly, some carriers can manifest symptoms, and all mothers will need monitoring with an echocardiogram starting at age 30, and then the recommendation is ongoing every 5 years. So if the child is affected, it definitely has implications for the family, so we always have genetics involved. So what is the dystrophin? Well, this is a very important protein. It's actually a very large protein. So if we take the muscle fibril and then take it down to the level of the muscle membrane, you'll see this large dystrophin protein here on the membrane. If it is intact, you have good muscle stability. If it's only partially intact, or the protein is truncated and partially functioning, this is where you get Becker's muscular dystrophy. So same gene, but very milder phenotype. And that's because you have more of an in-frame mutation. It still can make some functional or truncated protein. And so that membrane is less leaky. Whereas if it's Duchenne and it's an out-of-frame mutation, then you're not going to have any dystrophin. If you actually quantitate this on a biopsy, it's going to be somewhere less than 3% dystrophin on that biopsy with a diagnosis of Duchenne. At the bottom is the histology for underlying muscular dystrophy. So really all the muscle cells should look at a nice honeycomb appearance. And here you have big muscle cell or muscle fibers, as well as small degenerating ones. And there's a lot of purple here indicating that, yes, there's inflammatory cells, which then is going to result in fibrosis in the muscle. So where do we find this protein or dystrophin? Well, it's everywhere. So It's in the brain. The receptors are in the brain. This is why average IQ in boys is about 84. And this is also why they get early speech delay. And there can be behavioral differences seen as well. So there's a higher incidence of autism. There's also a higher incidence of obsessive compulsive disorder or tendencies. So it definitely involves the brain. From the standpoint of the heart, you can develop cardiomyopathy. Typically, this is developed in the second decade. Because there's weak muscles, you're going to have some bone softening because of lack of weight bearing, and most boys in their second decade will develop scoliosis. The muscle disease degeneration is progressive, and over time there is loss of ambulation. And then also remembering other muscles like your breathing muscles. So the diaphragm is becoming more weak. The intercostal muscles are becoming weaker and more fibrosed, resulting in restrictive lung disease. And as all these things happen, then the boy is at increased risk for developing underventilation at night and maybe needing BiPAP and other respiratory supports. I'll talk about those again in a minute. And then there can be other organs involved as well. All of the boys get a yearly eye exam, mainly because one of the treatments is steroids, and that increases their risk for cataracts. The natural progression of the disease is such that the average onset of walking is at 18 months, but then the preschoolers tend to be a little bit more clumsy. Remember, that's that 3 to 5 years where the diagnosis is initially made. And then somewhere between 8 and 12 years of age is the loss of ambulation. We do some timed motor functions in the clinic that will begin to indicate to me how long the boy will continue to be ambulatory. So we track those over time just to help to guide parents. In the teenage years is where the onset of cardiomyopathy it develops, and half the boys will have cardiomyopathy by the age of 18. There is ongoing respiratory decline. And the old natural history was such that the survival was into the 20s. And I have to point out that this is without any treatment. And so I think we're going to see a shift in this. The treatment does involve, as you can, a multidisciplinary team where you need a cardiologist and a pulmonologist and an orthopedist. And steroids is standard of care. It's been so for the last for several years. I'll still find families who are resistant to starting steroids because, of course, they're not without side effects. Particularly weight gain is always a concern. So we are having some new gene modifying treatments and some variants of steroids that are coming up with clinical trials that hopefully will give us some promising alternatives. So this is our pediatric neuromuscular house. And as part of our clinic, we do have an orthopedist, a cardiologist, a pulmonologist, a physiatrist. I have the endocrinologist see the boys on the same day if they are on steroids. We also have a nutritionist who monitors the growth and weight, and a genetic counselor, a neurologist, a coordinator, a social worker. I think at last count we had well over 20 team members. And we typically will do all these assessments in a half day. And currently are having weekly clinics to help to accommodate everyone. There are some nice videos. So if you do have a boy with Duchene's and they are not aware of some of these videos, see, I have some technology challenges, but just a minute. There's the nice stretches, and this may give the boys a visual at home and doing their stretches with the video. It is important. So the Parent Project Muscular Dystrophy site has all of those videos that any parent of a boy with Duchenne's can access and view those at home. I actually take similar videos with me to Nicaragua, where a local physical therapist reviews the videos with the families and demonstrates the stretches while they all have lunch. So I mentioned that steroids is standard of care. Prednisone was the first steroid that was used. There is alternative dosing where you can either dose daily at 0.75 milligrams per kilo per day, or you could use more of an alternative dosing regimen, maybe 5 milligrams per kilo per day with just weekend dosing. Because as we know, steroids can affect sleep. It can cause, weight problems. It can also cause elevated sugar, elevated blood pressure, and increased risk for cataracts. And so with the alternative dosing, the hope is that we can minimize some of those side effects, particularly the behavioral ones, and still get good effects. And there was a study with Ann Connolly that showed that. The steroids do cause a decrease in growth, so the nutritionist is monitoring the weight with each visit. It also will delay puberty and increase risk for fractures. So we're constantly doing lateral x-rays, at least on a yearly basis, to look for evidence of decreased vertebral height or compression fractures that indicate that we need to be more aggressive in their bone health. One of the alternatives to prednisone is deflazacort. This is a synthetic steroid. The dosing is a little bit different. It's 0.9 milligrams per kilo per day. Once the boys are no longer ambulatory, I will lower this if there's significant weight gain. Even after starting steroids, I tend to see them back in the clinic at 1 to 2 months. And if the weight is trending upward, I will always adjust the dose by about decreasing by about 20%, and try to keep them on the medicine rather than to discontinue it, or go to the alternative that they were on prednisone and switch to deflazacort. The deflazacort does use a specialty pharmacy and is delivered directly to the families at their home, so they do seem to like that aspect of it. And there is another steroid that is coming that is in research trials now that does seem to be even better than deflazacort. There was a head-to-head trial with deflazacort and prednisone. There may be some increased efficacy with deflazacort over prednisone, or at least that was seen in the trials. The newer steroid that is being researched currently, it's not and will go to accelerated FDA approval. Does maintain linear health and or linear height, and has cardioprotective effects. So there may be some new medications on the horizon. So this is what things look like now. So with steroids, we've been able to shift the loss of ambulation and shift the need for scoliosis repair by about 3 to 4 years. And then with some newer exon skipping medications, which are gene therapies, I think we're going to shift this further. So now we're definitely seeing adults living well up into the 30s. I think my oldest patient is 27 or 28 at the moment. And so transition is really important because all of our boys are living much longer than they did probably even 10 years ago. So I mentioned therapies. We'll start over here on the right. So these are the primary steroids. So the prednisone, the deflazacort, and the new one, the vamorolone, which hopefully will be coming soon. Then below that are looking at therapies that decrease inflammation and fibrosis in the muscle. So there are myostatin inhibitors. There are some that will maybe block the inflammatory response. So adalimumab, this one is an NF-kappa inhibitor. And so what you're trying to do there is decrease the inflammation going to the degenerating muscle so you can decrease the fibrosis. So if something like that worked, then maybe it could work in combination with a steroid and kind of be a cocktail of therapy. And then on top of that, you could use a gene therapy. And I'll talk about exon skipping, but what that essentially does is it's going to take out an exon that removes a piece of the puzzle that's not working to kind of push it together to work. Then there is AAV9 microdystrophin or mini dystrophin therapy that's been in phase 1 trials and has been very promising, where they actually take a modified adenovirus and they're going to insert the gene, but only the key components, because remember the dystrophin gene is very large. So they figured out which are the key components and put it in that virus to then affect the cells. And then they've looked at stem cells, and those are particularly the ones with cardiac stem cells are ongoing. But I think this top category with exon skipping and the AAV9 therapy is going to be where we see most of our newer therapies come from. There's still other exons that we can skip. So here's a nice demonstration of exon skipping. And so this is why it's so important to get that early diagnosis and to understand the genetics, because not every child is going to be amenable to exon skipping. One of the medications that is FDA approved is for exon 51, and there's about 13% of all the DMD mutations that are amenable to skipping 51. So if you look here in the middle, what this is doing is it's taking an out of frame mutation and making it an in frame mutation. So you see, if you can look at the top one, if you fit the left side of the puzzle, it's got to skip all the way over to the right and merge in order to fit together and to read that frame. So right now, with this change in 52 or deletion of 52, that couldn't happen. And this is why in the top picture, that boy has no dystrophin. But if he takes out this exon 51 and he can merge the two sides, then he can actually fit those two pieces of that puzzle together and get that truncated or shortened dystrophin and maybe have a milder disease more similar to Becker's. Does that make sense to everybody? So this is a table that looks at the exact mutation. So these numbers here on the table represent where the gene is deleted in the DMD gene and guides us to know, is the child a candidate for exon 51 skipper or exon 53 skipper, which are the two that are currently FDA approved. And when I normally am explaining this to parents, I said, you know, if you only have a C and a T, you're not really sure that that word is cat. But if you put a little A in it, then you're certain it's cat, but it might not look exactly the same. So what did the study show? So for the FDA-approved exon 51 skipper or eteplirsen, this did slow the rate of pulmonary decline. It was a 2.5% decline in the forced vital capacity as compared to 5% in the boys who what would be expected decline for the natural history. And there was a 2.8-fold increase in that dystrophin protein. Golodirsen is the currently approved FDA exon 53 skipper. It does show an increase in dystrophin expression beginning in the trials as early as week 48, and the mean percent of normal dystrophin protein, or the increase, was 1%. Then there is a third or a second exon 53 skipper, Larson, that is seeking accelerated FDA approval. And this particular one showed an average of 6% of a drug-induced dystrophin production. So not every exon skipping medication is quite the same. Some of them have better skipping efficiency. And that depends on what molecule that they're using. So this is where we began in Chore. This was our old Brook Road facility, and these were, I would say, the forefathers of neuromuscular here at the Children's Hospital of Richmond. And this is where we stood in 2017, where we were still getting a genetic counselor and a social worker, and we had not yet had our Duchene certification. And then this year, think that I'm steadily running out of places to put new people on the slide. So we've welcomed a new genetic counselor. I now have a partner, Dr. Nick Johnson, who's a pediatric neuromuscular specialist, as well as the young lady in red is she's also a pediatric neurologist who is double boarded in neuromuscular medicine, Dr. Thangara. Our team keeps exploding, and we try to stay very active in community events. So you may see us at MDA walks or family workshops. We do stay close as a team. We even have a pre-clinic conference to discuss each patient before, and this really helps to coordinate care for patients who maybe need a more significant surgery, like a scoliosis surgery. We can kind of talk about them from a cardiopulmonary standpoint and orthopedic standpoint before they even that child ends up in the hospital. There are a number of clinical trials that are up and coming that we've been involved in, and pretty soon I think that we will have a clinical trial for every child with muscular dystrophy, be it limb girdle muscular dystrophy, myotonic dystrophy, as well as some gene therapies for these particular muscular dystrophies. We have ongoing spinal muscular atrophy trials as well. So early detection is definitely high on our priority, so that we can get every child into a study or into a treatment as soon as possible. So a couple of take-home points from our lecture today. If you see motor delay, of course, get your CPK. And remember that Duchenne's muscular dystrophy does cause progressive weakness in boys, and this is a multi-systemic disease. So to also consider the cognitive effects and the cardiac effects and pulmonary effects. The best outcome is going to be having all the specialists together in the clinic, and that steroids do have a significant effect. And between steroids and our new gene therapies, treatment is here. So although this is a devastating diagnosis for families, I think this is definitely an era of hope, and especially considering that the gene for Duchenne's was not even identified, or was identified in the mid-'80s. To think that we've come so far in such a short time. A few questions. What is the best way to evaluate a 2-year-old for suspected weakness? Would you do manual muscle testing? Would you look at a functional assessment, including having the child stand from the floor? Would you do a timed motor function or refer to a physical therapist? If folks could just chat in with their answers, that would be great. Oh, Dr. Dowdery was able to join us. Yes, correct. Oh, very good. Everybody has the right answer. Yes, B, functional assessment, including standing from the floor. Second question, a 4-year-old boy with a history of toe walking and speech delay. His exam is significant for standing from the floor with a widened stance. What is the next best step to aid in his diagnosis? A, refer to or for a PT assessment. B, refer for PT and speech. A C, refer to a pediatric neurologist, or D, get a CPK. Oh, very good. Very good. Yes, D, obtain a CPK. You all get a A+. Very good. Neuromuscular clinics include cardiology, pulmonology, orthopedics, or D, all of the above plus more. Yes, D. I think I led you a little bit in that one. Very good. The last question, standard of care for Duchenne's muscular dystrophy includes A, steroids, B, multidisciplinary care, C, use of orthotics, D, sleep studies, and E, all of the above. I think I've seen a number of E responses, and the answer is E. I didn't talk about orthotics, but these are braces, particularly the night splints, need to be put in place as early as possible to kind of start that routine where the child is used to wearing night splints at night. This will help to prevent that contracture at the heel cord and actually aid in ambulating longer. But if you don't start them early, you're going to find a lot of resistance in getting them to wear them. So I think we achieved our objectives, and everyone has shown an improved knowledge in identifying patients with motor delay, that everyone seems to have heard probably multiple times when to get a CPK, and hopefully has an increased knowledge in the care of these patients and the new therapeutics that are on the horizon. We are changing the natural course of this disease. I need your help to identify them early, and please spread the word to your friends. I have a number of people to thank that helped me from day to day at putting these large clinics together. I did highlight Suzanne Spivey's name. She's my nurse coordinator for our neuromuscular clinics. She refers to our MDA clinic as the wedding. And if you can imagine having a wedding each week, you can know how much coordination goes into one of these clinics. These are my references for today. I'm not sure if you were able to see the videos or not, but I will play this one in the background while I take questions, because it seems that we are at the end of our time. So yes, the physical therapist can be certified in Duchenne's muscular dystrophy. It's a certification through Parent Project Muscular Dystrophy, and they go through additional training in order to get that certification, and oftentimes they have to be signed off by a therapist to get that certification. I apologize, I didn't do very, oh, well, hold on. Oh, I'm doing better with my chat. Okay. Oh, so one of the questions that did come up regarding the exon skipping, one of the newer Vitilarsen did show an increase of up to 14% in dystrophin production. That would translate out into this being a milder disease, so more of a Becker's-like phenotype than Duchenne's. This is what the data has showed, that actually that has just been published in JAMA this past month, and I have to say that my clinical experience with this particular clinical trial has been very similar. So it is a rare finding to see a 10-year-old who's still able to jump off the floor. So I think that medication does show a lot of promise. So steroids in general help the skeletal muscle function. They do not have the same impact on the cardiomyopathy. And so there definitely is some room for growth in that area. The newer steroid that is going to be pursuing FDA approval, vamorolone, does have the potential to have some cardioprotective effects, and hopefully we'll start to see data on that. There was another trial, the HOPE-2 trial, that was using cardiogenic stem cells. That data should be coming as well. But yes, cardiomyopathy is one of the areas that I think we need to focus on. At a recent Parent Project Muscular Dystrophy provider group that I attended, there is a cardiac registry that is a multi-site consortium that is being put together to help understand the natural history and define therapeutics. One of the things we have done to detect earlier heart dysfunction is normally about age 10, we are routinely getting cardiac MRIs if the patient's able to tolerate it. And that will show earlier fibrosis and is a more sensitive measure of the left ventricular function. So one of the other questions was discussing factors with the two infants with hypotonia. So I agree that looking at the family history is helpful, but of course, if it's spinal muscular atrophy, that's going to be recessive. You may not get a family history. And if up to 30% of the Duchene's boys, of course, they would not be seen as a hypotonic infant. The earliest thing that you might see in an infant for Duchene's would be having weakness with neck flexion. But the family history would be important for earlier diagnosis. So if you have a family history, screening with that CPK early would be important. If you have an infant with the hypotonia, remember that spinal muscular atrophy type 1 is the more common form. And if you don't see reflexes, that is a medical emergency and requires prompt referral that day to a pediatric neurologist, because the treatment, the gene therapy we have for that is time sensitive. If we can infuse the children with the newer gene therapy within the first 6 months, they do much better. If we can infuse them within 3 months, they may even get to walking and standing, which in an illness that previously was fatal in the first 2 years. The second video that I had for you all actually is a nice demonstration here of a baby who did receive gene therapy for SMA as an infant, so before 3 months of age, ended up having normal milestones. And if pretty soon this is going to be on your newborn screen. It's already been approved in the state of Virginia. And if you have any friends or families that you know the mother's pregnant, I'd encourage you to go ahead and have that mother get carrier testing, because if we can make this diagnosis early, then there'll be more little girls like the one here in the video who are up and walking at age 3 who had type 1 spinal muscular atrophy. I'm sorry, I think I went over for my time. If there's any other questions, please let me know. I will make sure that Janie has my email, and you're all free to reach out to me anytime you have a child that you're concerned about. I'd be happy to help. Thank you all.